ये पार्टिसिपेंट तो ऊपर है भी वॉइस तो नहीं ऑन Well, Bismillahirrahmanirrahim. Rabbi shrah li sadri yassir li wa yassir li amri wahlul 'uqdatan min lisani yafqahu qawli. Well, yesterday we started, in fact, we started this cardiovascular system for atherosclerosis, and I'm sure you must be having a lot of concepts about clear concepts about atherosclerosis, but the only thing which ये क्या आ रहा है? ये अनम्यूट किए हुए हैं वैसे
सर उनके कैमरे में
अच्छा कैमरे
मैं इनको खत्म कर
अच्छा अगर कैमरे भी ऑन कर सकते हैं वो
जी सर
ठीक है तो बंद भी कर हाँ चलो चलो Well, atherosclerosis, in fact, before I start the diagnosis of myocardial infarction, I must tell you that the ischemia as a result of narrowing of the vessels leads to ischemic heart disease, and that disease could be angina, or it could be stable or unstable angina, or spatral angina. But the acute coronary syndrome is the word used for myocardial infarction when necrosis is there. If the reversible injury is there, you can call it angina, but if it is of short duration. When it is prolonged, it can lead to this cardiac death or myocardial infarction or necrosis of the heart, depending upon which artery is involved and where that artery is supplied, and the area supplied by that artery becomes getting necrosed. So I told you that there is no laboratory investigation which can tell you that how much atherosclerosis is there. So you have to modify the modifiable factors. If you advise the patient for prevention of the factors which can be modified, so that is the only way you can guide your patients. How can you get prevented from atherosclerosis and the consequences of atherosclerosis, which is one of that is myocardial infarction, atherosclerosis in coronary arteries, and that MI or myocardial infarction is a serious condition. So obviously, modifiable factors आपको याद रखने हैं. So the question you need to remember is the atherosclerosis definition, the mechanism or the pathogenesis of atherosclerosis. Is it an intimal damage, and how? What is the pathogenesis, underlying mechanism which can lead to atherosclerosis, and the consequences of atherosclerosis, ischemia, and the different diseases which can, because of coronary narrowing of coronary arteries due to atherosclerosis, or an embolus from somewhere else. More commonly, it's a vasospasm and emboli are the rare cause, whereas 80 to 90% the ischemia is due to atherosclerosis. So what atherosclerosis can lead to, I have already told you, and the risk factors, that is another question. You need to remember modifiable or non-modifiable risk factors. And then from the risk factors, obviously, the one thing is, I told you that you have to lower down the cholesterol because it plays a role in atherosclerosis formation of the plaque. So atherosclerotic plaque formation में जब आपको lipids they play a very important role. It's the oxidation of lipids because of which the plaque formation is there. So whatever the underlying mechanism is, there is a very significant role of lipids. So lipids को आपको वो करने के लिए exogenous याद रखें, जो आप whatever the diet you take in is delivered to liver for metabolism, and some of it is metabolized in the capillaries. Yesterday I also told you the role of liver is, although it not only metabolizes the exogenous dietary fat, but the second thing जो दूसरी चीज है वो ये है कि it plays a role in the synthesis of triglycerides and cholesterol. लेकिन मैंने बताया था कि there is no negative feedback. Negative feedback का मुराद यही है कि अगर dietary fat ज्यादा हो तो liver take up, ये नहीं होता कि liver take up ना करे जी, I have enough lipids so it is not needed. But जितनी dietary fat आप लेते जाएंगे ज्यादा उतनी ही deliver होती जाएगी. अब liver क्या करता है, वो it throws into circulation very VDL, VLDL, very low density lipoprotein, और ज्यादा cholesterol circulation में होने से what happens is the LDL receptors on the hepatocytes, they are reduced. So the net result is कि जो lipid है वो circulation plasma में रहती है, and when there is more lipids in the plasma, there are more chances that it can get deposited in the peripheral circulation. So you have to suggest how the diet control. But आपको जो लेबोरेटरी क्या हेल्प कर सकती है वो यही है कि लिपिड में आपको लेवल ऑफ कोलेस्ट्रॉल क्या है, लेवल ऑफ बैड कोलेस्ट्रॉल क्या है, एलडीएल का लेवल, एचडीएल का लेवल, समटाइम्स पीपल ट्राइग्लिसराइड का लेवल. सो ये लिपिड प्रोफाइल सिर्फ आपको बताते हैं करवाने के लिए कि रिस्क फैक्टर्स कितने हैं आपके और which can be modified. So modifiable risk factor is the diet. इसी तरह exercise, you burn your calories, is the modifiable factor. Smoking या जो भी आप जितने भी factors हैं patient को जितने ज़्यादा advice देंगे उतने ज़्यादा risk factors कम होते जाएंगे, और जितने risk factor कम होते जाएंगे chances of atherosclerosis can be minimized, and if there is minimum atherosclerosis there are less chances of myocardial infarction. अगली बात जो आपको जाननी आनी चाहिए कि ये आपकी जो रिपरफ्यूजन क्या होती है, रिपरफ्यूजन से रिवर्सिबल इंजरी है और नेक्रोसिस है या स्कार बन गया है, और डिपेंडिंग अपॉन द ड्यूरेशन, द नैरोइंग, हाउ मच वेसल इज नैरोड, how many plaques are there, what is the condition of the plaque, whether there is hardening of plaque, fissure, rupturing, complications भी हो सकती हैं. तो आपकी ड्यूरेशन ऑफ इंजरी, स्कीमिया है, आपको बताता है इंजरी कितनी है, और उस इंजरी में आप फर्दर सीवियरिटी और फर्दर प्रोग्नोसिस या पेशेंट की लाइफ सर्वाइवल जो पेशेंट पूछता है वो बता सकते हैं, आप गाइडलाइंस दे सकते हैं. But once the necrosis is there and collagen deposition is there and fibrosis leading to scar formation, तो scar जब एक दफा बन जाता है, it is not reversible. So हाँ, जब तक scar ना बना हो तो hyperemia which starts from the periphery, और periphery से शुरू होकर ऐसा ऐसा सेंटर तरफ जाता है, तो जितना कम से कम necrotic area यहाँ दर्द ज्यादा है, occlusion परमानेंट होगी तो जाहिर है ज्यादा होगा, लेकिन अगर रिपरफ्यूजन हो जाए जल्दी 2 घंटे में तो हाइप्रीमिया स्टार्ट फ्रॉम हियर एंड देन, तो व्हाट हैपेंस इज द कोएगुलेशन नेक्रोसिस जो है ना उसकी एरिया ऑफ नेक्रोसिस बिकम्स रिड्यूस्ड एंड दिस कॉन्फर्मेशन इज रिड्यूस्ड। एक बात मैंने और आपको बताई थी कि व्हेन यू गो टू कार्डियोलॉजी यूनिट, तो जो पुरानी ईसीजी की चेंजेस है, अगर स्कार हुआ है तो पुराना इंफार्क्शन तो वो मौजूद रहता है एंड इट इज नॉट रिवर्स्ड। और एक बात कल बताई थी कि what you need to remember is the gross appearance. What happens is to the heart if internet if और जो microscopic picture जो आपकी हो सकती है वो वही है जो inflammation की होती है कि initially there is wavy और contractile myofibril जो है वो it becomes wavy, there is exudation, inflammation, inflammatory cells, maybe hemorrhage and finally और हाइप्रीमिया होने से फिर रिकवरी होने, अगर पेशेंट सर्वाइव करता है तो रिकवरी एंड फॉर्मेशन ऑफ स्कार। तो ये आप ड्यूरेशन के लिहाज से हो। So that was about, just a brief summary of what we taught, and but you need to remember at least that was my objective to tell you, because sometimes in online teaching you need to repeat the things of yesterday, maybe online campus, when you are directly interactive sometimes. So that is not a difficult job. You can ask the question there and then, and you can explain the things there and then. But I know there are problems in our country, that is the connectivity. So at certain places there is facilities not available, or there is no electrification or electricity available. So you face problems. So we need to just give you a summary of the previous session. Well, the diagnosis depends on the symptoms and signs, the biochemical evidence, and ECG pattern. These are the three things which are important. Symptoms and signs. Patient usually presents with pressure or tightness in the chest. So one can have tightness, feeling of sometimes shortness of breath, or the tightness in the chest. Sometimes it is more than that, and you have pain. And that pain, if you feel pain, if you stop and sit, that pain is relieved. That is just a transient vasospasm, but that transient vasospasm, if repeated or added with other pathology, that is atherogenesis, that can lead to unstable angina and myocardial infarction or necrosis. So short of infarction, there is a reversible injury, but once the necrosis starts, it is irreversible injury. So tightness in the chest or pain, precardium in the area of substernum or precardium. Sometimes people, they complain of pain in the backside. So well, that depends on the area where the infarct is and which artery is involved, whether it is a single artery और जो arteries मैंने आपको बताया था वो जरूर याद रखें, because when you will be a student of medicine, you will need to recall about these arteries. So arteries के लिहाज से ही आपका area of infarct होता है, और the area which is infarcted or coagulative necrosed, वो उस लिहाज से symptoms होते हैं. For example, if there is which is the very rare possibility, जैसे अब हम कल बात कर रहे थे कि that circumflex artery posterior which supplies to the backside of the right ventricle rather. So usually sometimes the people, they complain of pain even in the back, although there is it's only 1 to 3% possibility of having that infarction. The most common infarction is usually that of front of the anterior portion of the left ventricle and the apex. So that is 80 to 90%. उसमें usual symptoms जो है ना, इसीलिए sometimes people say कि ये symptoms तो हमें MI के या angina के नहीं लगते. So you have no idea which artery is involved and where it is located and which part the narrowing is there and which part of the heart is getting ischemia. So it's subject to the distribution, blood flow to that area. इसी तरह symptoms के मुताबिक. So you can say that substernal pain and precardial pain is the commonest presentation of a patient, but that pain can be in the back or it can go into the jaw and other areas of the body. It may, duration may be from minutes to even it can take to the deathbed. But shortness of breath, the patient usually is sweating. This is a very important symptom that any pain in the chest supplemented with sweating, you must think of angina, whether it radiates to the shoulder, left shoulder or not. Sometimes it radiates to the right shoulder also, but more commonly the pain is in the, as you see in this diagram, the area, and then it radiates to the shoulder and to the left arm. But that is the common presentation, and I have already told you it's only LAD or anterior descending artery occlusion, which is very, very common. Yes, it's common. And again, sometimes the patient presents with those symptoms which are not very common, and that is due to the different arteries involved. When you just see the pulse, it's rapid and weak. The another word written over here is that silent myocardial infarction. Silent myocardial infarction. So pain is a blessing. We always say pain is a blessing. That pain, जब होती है, patient usually presents with pain. Patient will tell the people around and can be taken to the hospital and can be provided. Help can be provided. But sometimes there is no pain and the patient has myocardial infarction. It is diabetes mellitus and elderly. I'm sorry. An elderly patient and in diabetic patients, mostly because of insensitivity due to nerves, and the pain is not being felt by the patient, and the infarction is silent, or the patient, in minutes, the patient goes away from your hands. So, but that was signs, symptoms and signs. The biochemical changes are very, very important, and those biochemical changes. I told you that there is no laboratory test which can help to tell you where is the atherosclerosis and how much is the atherosclerosis. Angioscans or the other procedure, invasive procedure, which are not done in the laboratory, in the cath lab, that can help you to locate the plaque, atherosclerotic plaque. But laboratory tests are available which can help you to diagnose myocardial infarction. That means if there is inflammation or necrosis has started in the myocardium, then there are tests which can tell you that the patient has got the problem, and you have to manage the patient accordingly. So based on the measurement of the blood levels of intracellular macro, in fact, the proteins, when the myocardium is injured or myofibrils, the cell membrane of those myofibrils, they are damaged. Those proteins, specific proteins, which are specific as well as very sensitive. So the difference in words specific and sensitive, you will learn it from the Department of Community Medicine, but just I want to give you a brief in one sentence. Specific means specific to the organ or specific to the myocardial fibrils. Sensitive means the test is very, very sensitive. That means it can pick the changes very early. So it's in the language of pathology, you can call that because the myocardial fibrils, when they are damaged, the cell, there is a leakage of proteins from the myocardial fibrils, and that protein is called troponin, or in short words, you call TROP, myoglobin and serum C-reactive protein. That is C-reactive protein, but C-reactive protein is a non-specific test. Similarly, myoglobin is also a non-specific test. In many blood dysplasias or blood diseases related to hematopoietic system, and CRP is also increased in corona infection. So inflammation in general can lead to increase in CRP. Myoglobin in general can lead to increase because of skeletal muscles as well as myocardium and in blood diseases. But the troponin is specific and sensitive test. We'll talk about a little more in due course of time. But the second thing is the cardiac enzyme. So I talked to you that the lipid profile and electrophoresis of lipoproteins are the two investigations. Lipid profile means cholesterol, triglycerides, and the components of cholesterol, that is bad or good or LDL. And the HDL cholesterols, they are for the prevention. So if the patient is suffering from congenital hyperlipidemias, you can lower down it and by your suggestions, or there are drugs available जो आपको they lower down if there is hyperlipidemia. So risk factor modifiable को change करने के लिए आप you have to do something else. But once the necrosis or inflammation has occurred, you have a laboratory investigation to pick it up, whether the chest pain is because of pleurisy or respiratory problem or any other problem, pneumonia, or it is MI, or maybe related to even stomach. Peptic ulcer pain can also be felt in the chest. So in differential diagnosis, there are certain tests. Once the inflammation or necrosis has started in the myocardium, then the tests are available, and those tests are number one, proteins, and number two, enzyme. And more than that is ECG. Always remember one advice I must give you: if you get a patient, you receive a patient in the emergency, and you suspect that the person is having cardiac problem, instead of taking a sample and sending it to the laboratory, waiting for the result, immediately do the ECG, then electrocardiogram pattern or the changes in the waves. That becomes more important. And till the time you receive the report from the laboratory, that information can be confirmed that the patient is having some problem related to myocardium. So just troponin, myoglobin, serum, CRP. I told you that C-reactive protein is non-specific, but still you can ask for this investigation. And this will tell you that some inflammatory process is going on, but it may be the pleural pleuritis. That is not very useful test. But in corona patients, the latest is CRP quantitative estimation has gained a lot of significance, because every few hours change in CRP will tell you how much speedy the inflammatory process is going on. That does not confirm the diagnosis, but that tells you the management point of view से आपको ये पता चल जाता है कि अगर सुबह क्या condition के patient की 3 घंटे के बाद क्या है, 6 घंटे के बाद क्या है. If the inflammatory process is with a very great speed, the quantitative CRP shows very high peak. So that is for the management, not for diagnosis. TROP-T and cardiac enzymes are, we talk about that in due course of time. For example, when we talk about TROP-T, there are isomers. It's a contractile protein of the myofibrils. So I have already told you that the myocardium, when it is inflamed or necrosed or damaged, you can call it, there is a leakage of proteins from the cell membrane into circulation, and you can measure them. So this TROP-T isomers भी measure कर सकते हैं, आप total TROP-T भी measure कर सकते हैं. So this TROP-T is very important. For example, over here, troponin and the isomeric forms, that is troponin T, troponin I, and troponin ultra. So these are different types of troponins जो आपको बताती हैं कि there is a level of protein which is being leaked from the myocardium, so it's very important. So total troponin and its isomeric form, that is tropomyosin binding TROP-T is a tropomyosin की वजह से we call it. This is C troponin T. So T isomeric form of troponin, and this inhibitory troponin or another troponin is calcium binding. This calcium binding troponin, which is CTNC, capital C, and this troponin calcium binding is non-specific. When you compare these isomeric form, some laboratories they measure the total troponin. Some measures can have measurement of. It's very simple investigation which can be done in minutes, and you can have a result. So this the difference between troponin isomeric T and I is this troponin I, which is an inhibitory troponin, is more sensitive and more specific than TROP-T if you are measuring the isomers. Trop T और इसमें एक फर्क ये भी है कि this is more sensitive and more specific, but this is in comparison to I. This Trop T is a little less specific and less sensitive, but this troponin has got a wider zone. So तीन बातें मैंने की हैं, एक sensitivity, एक specificity और एक zone. When you say wider zone, that means the appearance of Trop T in circulation is a little early and it stays there. The raised level of Trop T stays there for 10 days. So there is a wide zone. आज आपको अटैक हुआ है 8वें 9वें दिन आप सोचते हैं कि वो पेन कहीं मुझे MI की पेन नहीं थी, तो still you take a sample, you will find that the Trop T level is raised. लेकिन Trop I जो है वो जल्दी it becomes. So that is, if you take a graph, you can find it that early to come and late to go, that means the zone is wide. Sensitive means it can pick the disease at a very lower concentration. Specific means both are specific for myocardial damage. Troponin calcium binding is not. In skeletal muscles or myositis or other muscular skeletal muscle disorders instead of cardiac muscles, this Trop C or troponin calcium binding protein also shows a rise. So when the differential diagnosis ज़्यादा जब हो जाए तो इसका मतलब ये है कि उसकी specificity कम हो जाती है. So troponin calcium binding, as it shows a rise in skeletal muscle disorders also, like myopathy, skeletal muscles myositis, or skeletal muscle disorders like. तो इसलिए ये इसे नॉन स्पेसिफिक कह देते हैं, but troponin T and I are sensitive and specific. The normal levels are, this is given over here. Another is the advancement is that Trop I की form एक और आ गई है, that is ultra Trop I. The measurement of assay by the this I or ultra Trop I, that is the highly sensitive, you can call it, in comparison to other these two isomeric forms, that is Trop T and Trop I. But remember, the single test is sometimes not helpful for the diagnosis of MI. It is better to immediately take the electrocardiogram and then you take the sample simultaneously, send it to the laboratory for not only for Trop T or Trop I, but also cardiac enzymes. And those enzymes we'll talk about a little later. So this was, I don't think so. I need to tell you that what is the level and when is the peak achieved and when it comes down, the whole graph. You need only, you can read it from the books, because in lectures, even if I tell you, you won't be able to recall it. You can see it from the books or from the knowledge of E-Lab or somewhere else. But this is the diagnostic way of doing the laboratory, just to have an idea of why you receive the test so quickly. Well, this device is called chromatographic device, and there is, you can see it over here, there is a well. You just add serum sample over here, and this well has got paper impregnated with anti-protein, or if you use the word I don't want to use antigen and antibodies over here. There are also proteins, but proteins and anti-proteins you can call it. If you place the sample, a drop of serum on here, that will diffuse through the paper, and you can find, for example, this is positive, this is negative. This is controlled. That means when that serum has got troponin, the protein will bind with the anti-protein, and that will make a color. That is the reason we call it immunochromatography. Immunochromatography means ICT devices, you call it. The word immuno is not good over here, but it's a chromatographic device, you can call it. Chromatochrome means color, so it gives us just a colored line. If there is a single line, the test is negative because it's a control. It's already anti-protein is there which binds with that and gives you a cut. But if instead of this, there are two lines, that means it's a control, this is patient value. So serum में अगर है patient के तो पहले ही line आ जाए control तक पहुंचने से. तो वो जो जैसे जैसे वो filter paper से diffuse करता है serum. So the two lines means positive and the one line, single line means it's just after 2-3 minutes you can read the tests. Well, these are the values. So you can imagine 0.01 drop T. It is so sensitive that it can measure 99th percentile of people. Without cardiovascular diseases, the value is this. It's very, very. But if it increases in this is the, as you can see, the pink. तो जैसे जैसे ये concentration ज़्यादा होगी वैसे वैसे ये color ज़्यादा होता जाएगा. And this is the level at which you can say that the person has got acute coronary syndrome or ACS or MI. You can say AMI, acute myocardial infarction, or acute coronary syndrome. And amongst the acute coronary syndrome, you have a group of disorders which are placed in ACS. So आपको अगर कोई पूछे कि what is acute coronary syndrome, you need to tell angina, types of angina, sudden cardiac deaths, cardiac arrest, and myocardial infarction. So लेकिन ये इतनी concentration जो है तो normally भी होती है क्योंकि normally भी heart contract करता है, थोड़ी बहुत leakage होती रहती है. But here it is 99% लोगों में ये level होता है और 10% लोगों में यहाँ तक भी होता है. But if the concentration is more than 0.1 this microgram per milliliter, you can call it a positive test. Similar is for drop I. Well, myoglobin, the levels are 0 to 85 nanograms per liter. I have already told you iron and oxygen, they bind to this protein. So it is also raised in cardiac muscles as well as skeletal striated muscles. I'm sure you know it that the smooth muscles ki yahan baat nahi ho. It's related to hemoglobin as well. So I have already told you that it's a non-specific investigation which shows a rise in RBC's disorders and striated muscle disorders and cardiac muscle disorders. So myocardial infarction, this muscular dystrophies, myopathies, and myositis we talked about already. Damage to all these cells can lead to this a rise in myopathy. So I don't think so. One should take very seriously that one should ask for myoglobin level assays. लेकिन अगर कहीं से कुछ भी नहीं मिल रहा तो you may advise the patient that there may be a possibility of MI. Well, when we talk about the cardiac enzymes, the enzymes are one of the most important enzyme is creatinine kinase. You already know it. The nomenclature of enzymology, the latest nomenclature is CPK. Well, why I call it CPK? The three-lettered word enzymology में जो है वो they are used mostly. पहले तो 4 लफ्ज भी use होते थे. For example, AST, aspartate transaminase, previously it used to be called as SGOT. It's 4-lettered, 2-lettered. Now the Society of Enzymology have switched over to that there should be 3-letter word used. So consensus ke baad, mostly I'm sure it's subject to biochemistry, you must have learned it, but in enzymology it's better you use the word CPK instead of CK. लेकिन हमारे लोगों की आते हैं कि हम शॉर्ट कट्स पे जाते हैं, हम तो ये भी लिखना गवारा नहीं करते कि किसी की डिटेल्स लिखने. I tell you one thing, very this is my advice as a teacher कि आप जब डॉक्टर बनने के बाद you write the prescription or you write the investigations, kindly do not use the abbreviations because sometimes the abbreviations carry different meanings and when you will get a different report, you will say what laboratory is playing. So कई लफ्ज ऐसे हम, for example, MI में मैं आप बात कर देता हूँ cardiovascular, although that is never confusing because mitral incompetence is a disease of children and that is also cardiovascular disease. congenital heart problems may that the mitral valve is incompetent. Yesterday I also talked that there is a regurg. So when there is stenosis, the blood does not flow. There is obstruction. When there is incompetence, it is unable to close completely. जब atrium से ventricle में जाता है, so ventricle, if the mitral valve is incompetent, what happens is the blood flow from ventricle goes to atrium again. That is called regurg. So regurgitation tab hoti hai jo mitral incompetence. Although that is a disease of childhood and it's a congenital disorder, but it can appear later in life as well. For example, if the murmur is there, you place your stethoscope on the chest and murmur is there, that is telling you that MI is there. You may not pick it. For example, if it's a very small, the valve closes, but it's quite competent, or incompetence of valve is very mild. So regurg is also mild. So you may not be listen to the murmur very carefully. और एज बढ़ती जाती है और जैसे जैसे बढ़ती जाती है रीगर्ज से वो इनकॉम्पिटेंट वाल्व जो है ना वो ज्यादा स्पेस बनाया जाता है एंड मे अपीयर इन लेटर एज मे बी 14 16 और एमआई भी हो सकता है उसमें किसी और प्लॉट पहुंचने की वजह से जरूरी नहीं क्या माइक्रोल इंफार्क्शन यूजुअली इज सीन विद एडवांसिंग एज बट सो मिक्सअप ऑफ इन्वेस्टिगेशन जैसे मैंने अभी बताया कार्डियोवास्कुलर सिस्टम में ही एमआई स्टैंड्स फॉर myocardial infarction more commonly, but when it's a boy of 14 or 16 years, it may be mitral incompetence. So my sincere suggestion to you is can never you go for abbreviation when you write a prescription or you write laboratory or radiological help. बहुत दफा ऐसा होता है कि दवाई का नाम आप एब्रीविएशन में लिख देते हैं जो फार्मासिस्ट है उसे कुछ और पढ़ के दे देता है और पेशेंट जो है वो आपका खाम खा वो मेडिसिन लेता है सो बेटर ट्राई टू अवॉइड इट बट CPK mean creatinine phosphokinase. So the CPK, the isoenzymes, you need to remember that one is total CPK. So creatinine phosphokinase is also not very specific. It is written over here that rather you can say the isomeric form, it's also coming from the brain. You already know it, it's also coming from the striated muscles. So it is non-specific. But the gold standard is that the isomeric form which is coming from the heart, that is CKMB. So ECG, electrocardiogram, plus troponin T or tropi or troponin total. The third investigation, CKMB. These are the three investigations which are gold standard and should be immediately asked for once you suspect a patient of myocardial infarction. So as I have told you that there are three isoenzymes, one is BB, it's also called CK1, that indicates damage in the brain. It's also raised in strokes and trauma and other causes, whereas CK2, that is MB, which primarily indicate of cardiac muscle damage of the myocardial damage, and but it can also be found here. You see the smooth muscles, they also have small intestine, uterus, prostate, and diaphragmatic diseases may be. But I have already told you that this is not the only enzyme which you should ask for the diagnosis of myocardial infarction. You have to ask for a better laboratory investigation. The CK or CPK rather, total CPK, it starts rising 4 to 6 hours. So you can see that the increase in circulation, which a laboratory can help you, shows only after 4 hours. लेकिन उस 4 घंटे से पहले जो चेंजेस इस्कीमिया के हैं वो तो प्रिडिक्ट नहीं करती लेबोरेटरी, वो आमतौर पे इलेक्ट्रोकार्डियोग्राम से पता चल जाता है. बट उन 4 hours में there is a normal CPK level or CKMB even level, so you should not exclude the diagnosis of MI. आप 3-4 घंटे के बाद अगर पेशेंट सर्वाइव करता है दोबारा करवा सकते हैं वो फॉर योर हेल्थ. बट रिमेंबर, a negative report does not exclude myocardial infarction. The rise starts from 4 to 8 hours. The peak is achieved in 12 hours. ये graph याद रखने का फायदा सिर्फ यही है कि for example, if the patient comes to you after 4 days, कि जी मुझे 4 दिन पहले पेन हुई थी, so it has already the concentration of CPK, the blood levels, वो तो normal हो जाएंगे. So what is the fun in that? Similarly, intramuscular injections लगाने से patient को nurse ने intramuscular injection लगा दिया है, striated muscle में लगता है ना वो, तो muscle injection से भी ये थोड़ा सा rise आ सकता है, myositis से आ सकता है. Exercise, vigorous exercise करें उसमें भी बढ़ जाता है, so trauma में बढ़ जाता है, whether it is surgical, even in cerebrovascular disorders like convulsions and tremors, delirium उसमें भी बढ़ जाता है. तो when this total CPK increases pathologically and science and physiological conditions like exercise, तो उसमें फिर ये नॉन स्पेसिफिक हो आप इसे कह सकते हैं, लेकिन it is a test which can be supplemented with electrocardiogram and troponin. तो ये इसका जो लेवल कब बढ़ना शुरू होते हैं, कब पीक आती है, तो अगर पेशेंट की ड्यूरेशन ऑफ इस्कीमिया स्टार्ट आपको कई दफा नहीं पता होता तो उसके अंदाजे के मुताबिक 1 से 2 दिन के दरमियान पीक इज देयर and it starts coming down in 3 to 4 days time, and when it after 4 days you will find a negative report. I'm talking about total CPK. We've already talked about the CKMB or CK2, the isomeric form, is more specific for cardiac muscles in comparison to CK1, 2, or 3. CKBB is from brain, CKMB from cardiac muscles, CKMM from muscles. So, वो isomeric form ज़्यादातर. So coming, you can see this is what I was telling you. You can never think of one investigation. The gold standards are electrocardiogram and these troponins, troponin T, troponin I, and CK. Myoglobin ये वैसे इस ग्राफ में आप कह लें, बहरहाल ये it is not 0 hours, so it starts rising over here. And similarly, this is trop T, and this blue is trop I. Focus circular. This violet color is top T and this blue is top I at CPM. So ये आपको ग्राफ सिर्फ ड्यूरेशन बता रहा है. So this is the time basically in days. This is 1 day. So if the ischemia has started in 24 hours, you can find that the peak is there. और इसके पहले और इसके बाद की कंसंट्रेशन जो है ना वो वेरिएबल हो सकती है. सो आपको ईसीजी पे भी ट्रस्ट करना पड़ता है और प्रीवियस ईसीजी भी देखनी चाहिए अगर अवेलेबल. Now you can see it's just well, the other enzymes are lactate dehydrogenase, aspartate transaminase. Again, they are non-specific. Lactate dehydrogenase तो बहुत सी कंडीशन में बढ़ जाता है. ये इसी तरह का ग्राफ आप सोच सकते हैं. SGOT is also sometimes helpful. It shows a rise. So, a joint report of investigation of different enzymes and proteins and ECG is always more helpful. So here you can see the CK levels कब बढ़ता है कब. इसी तरह LDH की भी isomeric forms होती हैं 5, LD1, LD2, LD3, LD4 and LD5. LD1 is the isomeric form. Is the facility is available in the laboratory. LD1 is more specific for cardiac for myocardium, whereas LD5 is specific for striated muscles. So this is the important thing you need to remember is that serial estimation of these markers are preferential choice in the treatment and management of myocardium. मैंने पहले बताया है क्योंकि ये ड्यूरेशन ऑफ इस्कीमिया से रिलेटेड है तो सीरियल एस्टिमेशन आप करवाएं. एंड रिमेंबर वन थिंग व्हिच इज यूजुअली हाउस जॉब करते वक्त आप गलती करते हैं या रजिस्ट्रार बन के, एंड दैट इज व्हेन यू गो फॉर सीरियल एस्टिमेशन. इसका मतलब है कि पेशेंट का नाम, नंबर, आइडेंटिफिकेशन, सेक्स वगैरह लिखने के साथ साथ उसके ऊपर फॉर एग्जांपल 16 मार्च है आज, 16/1, 16/2 या टाइम लिखे थे साथ. अदरवाइज जब लेबोरेटरी में ऑर्गेनाइजेशनल सेटअप कुछ ऐसा होता है कि मॉर्निंग की ड्यूटी किसी और की होती है, इवनिंग की कोई और होता है, और उसके ऊपर ना लिखा हो तो नंबर 2 सैंपल को नंबर 1 समझ के कर लिया जाता है, 1 को 2 समझ के. So the values will be then confusing, and then you will have, as a clinician, you will face the problem. So serial estimation, ECG changes, ये सारी important हैं और gold standards के लिए आप एक वक्त में सारी चीजें साइन सिम्टम से लेकर ECG और बाकी proteins and cardiac markers, combination of that should be done. So well, there are certain other conditions in which the cardiac markers, they are raised, but they are not the diseases of myocardium. So तीन चीजें मैं आपको बता रहा हूँ, एक myocardial infarction, एक other diseases of heart और दूसरी non diseases of heart. और चौथी बात कि chest pain जरूरी नहीं है कि वो myocardium की वजह से. So there are four things which are important. There are four things which are important. एक आप याद रखें, cardiac ischemia can be seen in heart muscles, pericarditis, myocarditis, hypertension, cardiac failure, cerebrovascular accidents, shock and heart failure, cardiomyopathies, and cerebrovascular the strokes, that is called cerebrovascular accidents. तो एक तो ये है कि cardiac enzymes और या cardiac markers, cardiac enzymes in particular ना सिर्फ मायोकार्डियम की डैमेज की वजह से इंक्रीज हो सकते हैं, बल्कि नॉन एमआई में भी हो सकते हैं इंक्रीज. नंबर वन, हार्ट के दो हिस्से कर लिया, एमआई एंड नॉन एमआई, और उसमें ये है पेरिकार्डाइटिस, मायोकार्डाइटिस, कार्डियोमायोपैथीज. फिर इससे हट के स्ट्रोक्स वगैरह में या स्ट्राइटेड मसल्स में भी रेज हो सकते हैं. फिर ये भी है कि पेन है और एंजाइम रेज नहीं है, इसका मतलब ये नहीं है कि एमआई. तो ये ECG की चेंजेस आप देख सकते हैं. देयर इज दिस, यू विल learn much more in the units of myocardial, but remember elevation of ST segment and inversion of T wave, these are the two changes which reflects ischemia. Those changes, ST elevation, you can see it over here in the second here, and this inversion of T wave, ये inversion है. Yes, ST elevation. ST elevation and inversion of T wave are more important. एक चीज रह गई है, that is complications. You can read it. कि जब भी मायोकार्डियम इस्कीमिया हो, तो जैसे मैंने कल बताया था, मॉटलिंग होगी और इन्फ्लेमेशन होगी, नेक्रोसिस होगी, हीलिंग भी हो सकती है और डैमेज भी हो सकता है. डैमेज में रप्चर हो सकता है, एन्यूरिज्म हो सकता है, थ्रोम्बस फॉर्मेशन हो सकता है, एंडोकार्डियम थ्रोम्बस फॉर्मेशन हो सकता है. और जो हम in coming session we will read it, and there could be pericarditis. So these are the complications. ये भी पढ़ लें. So if you are being asked that what can be the complication of myocardial infarction, so starting from rupture, aneurysm, thrombus formation, inflammatory condition of pericarditis. Obviously, if it's a transmural thrombosis, तो वो inflammation extends throughout the wall. तो वो एंडोकार्डियम की तरफ अगर जा रही है तो वहां थ्रोम्बस फॉर्मेशन होगा, पेरिकार्डियम की तरफ जाती है, पेरिकार्डाइटिस होता है. और जब आपको पता ही है कि जब इन्फ्लेमेशन होती है तो वॉल वीकन हो जाती है, देयर कुड बी एन्यूरिज्म, देयर कुड बी. तो याद रखने के लिए कोई बहुत रॉकेट साइंस नहीं चाहिए. यू नीड टू लर्न द पैथोलॉजी, यू विल लर्न द कॉम्प्लिकेशंस. तो ऑब्वियसली इन्फ्लेमेशन अगर अंदर से बाहर स्प्रेड कर रही है, पेरिकार्डाइटिस, नीचे की तरफ जा रही है एंडोकार्डाइटिस. जब एंडोकार्डाइटिस होगा, इंजरी होगी, एंडोकार्डियल थ्रोम्बस फॉर्मेशन हो जाएगा. इसी तरह रप्चर हो सकता है. नेचुरली जब वीक वॉल होगी तो देयर कुड बी एन्यूरिज्म, और वो एन्यूरिज्म रप्चर भी हो सकता है. So these are the complications. You can read it more from the books. And thank you very much. मैंने कहा भाई कल नहीं आ गए. अच्छा वो हो, सॉरी.